because 90% of insurances only cover 12 visits. So they're going to go 3 times a week for 4 weeks and then kick you out the door. Or 2 times 6 and kick you out the door, depending on their patient volume. They're like, what? You didn't even look at this paper. I'm like, I didn't. I just know this is the process. And I'm like, I bet you doc gave you painkillers and muscle relaxers, told you not to do anything for 2 weeks, and then come see PT for 4. You're in my head. Hey guys, welcome back to Towel Talk. You can see the extra large pile of towels this time around because Andrew and I have decided to take on the topic of imaging and treating the image versus treating the person. And we're going to try to keep it at our normal rate, but we know we both have already talked about we can get pretty chatty and opinionated about this topic.
Yeah.
What's your initial take? Yeah, deep sigh.
It's one of those things where I feel like we just have to keep educating people as much as we can on them not being their image necessarily. And unfortunately, I think that there's a lot of folks that work against us in that of, oh my goodness, like we got to get an image on this. Oh my goodness, this is the worst image I've ever seen. Oh my goodness, you need a surgery right away. And
I don't know how you're living with this. I don't know how you're moving with this.
How's this even working right now? Like we got to get, and so it causes a lot of fear in folks. And then, I mean, we've talked about pain so much to the point where we know just instilling that type of fear in someone can lead to them having physical pain there.
More pain.
Just because you're starting to scare them. And there may not even be tissue damage there that is contributing to any type of pain experience at all. It can be just normal wear and tear that you get from aging. It can be sometimes, and there's cases where like, okay, maybe there's something there that we want to keep an eye on. Right. You know, we just want to make sure you don't make it worse later. But there's so many times where I've heard, I was just talking to someone the other day who got an elective surgery because their doc told them they have arthritis in their knee. So you need a total knee replacement. And I said, well, were you having pain? No. Were you limited with any of your daily activities? No. Did you lose any flexibility? Right. No. Was there swelling? No. Was there anything there? Right. No, it was fine. It was just there was arthritis in there.
Right.
Like,
and what you just said,
the
verbiage,
God.
You need surgery versus them calling it elective surgery. If it's a need, we're not electing to have surgery. We have to have surgery, right? So it's even that alone right there is counterintuitive to, oh, let me go have elective surgery because I need it. No. It wouldn't be called elective surgery if you needed it. Yeah.
So
and
I just
kind of going back to that whole imaging thing, and it blew my mind in school when they talked about some of these imaging stats. And one that I always go back to is 80% of 25-year-olds and older have some sort of disc herniation on an image, but the vast majority of them are asymptomatic. There's no symptoms associated with that disc herniation whatsoever. So going back to an image and using that as your catalyst for treatment or surgery or injections or medications is silly. You know, I even tell my clients, I'm like, imaging is our best guess at what's going on. Like, what do you mean? The MRI shows everything. I'm like, it's our best guess at that moment in time, in that position, what your tissues are doing. That doesn't mean if you're standing up, it's the same, or sitting down, it's the same, or moving through, exercise or activities is the same. It's just that moment in time. It's our best guess is what's going on. Sometimes we see things that are not there. Sometimes, the positioning matters. What's in the way, what's not in the way, what clothing are you wearing, There's so many, what type of machine, there's so many new technologies now. You're in an old MRI machine or an older X-ray machine, your image is looking much worse than one of these newer ones. Sometimes a diagnostic ultrasound now is much clearer than one of those old school X-ray or MRI machines. So there's so many other factors. And let's not even talk about the human error component of who's reading this, who's looking at it, Is it a radiologist that sits in a back room staring at images all day long? Okay, this was their 1,000th image of the day versus their first. How accurate are they? You know? I think about me looking at a computer screen for that long. my eyes do terrible things once we get later in the day.
Yeah.
So it's the education component is almost an uneducation component from by the time they get to PT of what they've been told about their images.
Yeah. Because I used to people would be mind blown sometimes when I would tell them, oh, thanks for this MRI report. I'm going to sit it over there.
Yes.
And
immediately
tell me about like what's going on.
I'm glad there are the clinicians out there that do that.
Yeah.
Yes.
Because they're like, do I need the MRI report? No. I mean, if you have it, cool, I'll look at it.
Yep.
But why don't you just tell me what you think's going on? What have you been dealing with?
Mm-hmm.
Well, don't you want to look at the x-ray? I mean, if you have it right here, yeah, we can look at it. It's not going to change anything that I do today. If it were something on there that was going to change what I'm going to do today, you probably wouldn't be sitting in front of me right now.
Precisely.
You know,
you'd be in the ER.
So I'm still going to evaluate you thoroughly, and we're going to go based off of what I see you do, and what you tell me you can and cannot do, and then we'll go from there. You know, but just to solely just look at the MRI, just look at the imaging, and then go from there. It's
a good way to be substandard as a clinician for sure. If that's your only or a key component to your evaluation process, it's almost handcuffing yourself to the back. I'm only looking at this because this is what this paper told me to do.
Yeah,
I do the same thing when clients come in. You know, I'd set it aside and never look at it, never chat with them. But now I almost use it as an opportunity to re-educate them about it. Like, hey, bring in your X-ray, bring in your MRI. Even if you have the discs, bring all that stuff in. We'll talk about it. Like, oh, you'll do that? Can you tell me what's going on? I'm like, I can't diagnose things based on looking at this stuff. That's not in our scope of practice yet. But I can look at it and kind of explain things about what's going on, what I'm seeing, describe what I'm seeing on the pictures, you know, so you have a better understanding of what's going on. And then if you have the actual physical report, I can talk to you about what the terms mean. Because I'm sure you don't understand. They're like, oh, thank God. The doc went through it for 2 seconds. He had the paper in his hand. So I couldn't even see the words that he was talking about. I don't understand. Yeah. He said it was the worst herniation or the worst knee or the worst arthritis. I don't even know what that means. What is arthritis? What is a herniation? What is 3 millimeters? I'm like, that much.
Yeah.
Like, he made it sound like I was going to die if I picked up a pencil off the ground. I'm like, you're going to be okay. You're going to be okay. All right. So now I use it as an opportunity. Like I set it down. I'm like, well, don't you want to? Like, I'm going to look at it, absolutely. But let's talk about what's going on with you first. Yeah. I want to hear, well, I already filled that paperwork out online. Perfect. That's for our records. I want to hear from you. I want to see how you react to this conversation. I want to see everything that's going on. Like, really? Nobody asked me to tell the whole story. Where do you want me to start? The beginning. Oh, we're going to be here a while. Perfect. We got an hour. Yeah. Let's talk. You would do that? Yeah, absolutely. I would do that because I want to know why you're here. And if that means we're sitting here an hour to get to the bottom of why you're here, absolutely. Especially things like back pain and talking about chronic pain, things like that. Oh, those have a lot to unpack, and it's not just the physical; it's the mental, it's the emotional. There's so much that we have tissues everywhere around the clinic for that reason because you start asking those questions. Yeah, they're like, "Holy hell! Nobody's asked me this. No one's talked about any of this. You think this is from 25 years ago when I had this injury?" I'm like, "Yeah, that's when you said your original back pain injury was." Well, yeah, that's when I had that first herniation or that first episode. Couldn't walk for 3 days. Took a month to heal. Never did anything about it. It's probably still part of the same thing that's going on that your body never fully recovered from. Physically, maybe the thing's healed, the tissue's healed. Yeah. But mentally, emotionally, you're still tied to whatever happened. Oh yeah, you know what? I had a giant financial crisis during that time. I had to walk to work for a month. Yeah.
A lot of stuff to unpack.
That X-ray and MRI doesn't show any of that. It's not going to
show any of that.
If I only treat the back pain based on he's got a 3 millimeter herniated disc at L5S1, we just miss treating this patient and actually having a successful outcome. Yeah, for sure.
Yeah, and the funny thing for me, I don't know if you've had this problem, but when I am doing rehab with someone and things are not making sense, and I start suspecting stuff and then go, you know what, we probably should get imaging to help us out here. that is the hardest time to ever get any imaging.
Yep. Yeah, because then nobody
It's the
wants it or
hardest
they
time
can't
to
get
get
in.
it. It is the hardest time to get it. And that's the time where I'm just like, no, I think we need this
Right.
now.
Yep.
You know, like we probably should get it,
Yeah.
you know? And then it's hard to get it.
Need to get insurance pre-op.
Insurance doesn't, then it's this whole thing. You go back and
booked
forward.
for the next 6 months.
Yeah. And I'm like, how'd you get that other image so fast? The one that didn't mean anything. How'd you get that? You know, the one that you didn't have any pain or anything like that. And
they hadn't met the
and
deductible
the
yet,
ortho's
so
telling you to get a surgery. You know, like how'd you get that imaging so fast?
Yeah.
But yeah, it's definitely something that can be, I think for some folks, very, very tough. Because even me, before I really got into the PT realm and learned a little bit more, I kind of had that mindset of, well, I better just get an MRI to see what it is that happened, so then I know how to treat it.
Yep.
And it's just like,
I need to see. I need
I
to
just
look
need
in
to
there.
see it and look and see what's there. It's like, well, what if we get that image and there's nothing there?
Right.
Which I've seen happen before.
100%. Yep.
Then what?
Yeah.
And I always ask people that. I'm like, you're really set on getting this imaging done. If the imaging shows nothing, what's your next step?
Right.
What's the plan? What do you want to do about this? I'm not saying there's nothing there, but I'm just,
think about it. Yeah.
let's just think about this.
Yep.
Where are you going next? What's the next step going to be? Because if the next step is crap, I still don't know what's wrong with me. I'm still having this pain. I'm still having this. Exactly.
Yep.
You just start spiraling. So I'm like, well, let's figure that out first. Let's figure out the next step either way.
Yep.
If they find what you think's there, or if there's nothing there, let's start working on that next step together.
Yep.
You know, let's just do that now. And then you may actually notice, oh, things are actually getting better.
Yep.
Oh, things are actually not that bad.
Yeah.
Oh, you know what? My docs, since we already been waiting this long, they're just going to go ahead and do it. But I don't even think I need the imaging. And then at that point I go, well, you know what? You're doing great. You probably don't need it.
Yep.
You know, if you really want it for your own records, like,
Sure.
that's
fine, I
up
guess.
to you.
Yeah.
But why? For what?
Yeah.
At that point?
Yep.
For what?
I have that conversation a lot with folks. They're like, oh, well, should I do this? I'm like, are you going to have surgery? Oh, no, I'm in PT. I don't want to do surgery. Like, I'm trying to avoid that. Great. Don't do the MRI of the X-ray then.
Why?
Like, unless we're worried about a fracture, unless we're worried about something significant going on, which based on the conversation and the evaluation, we're not. Don't have the MRI. It's not like that script expires. You can take it anywhere, anytime.
Yeah.
6 months from now, it'd still be good. It's not going to expire on you. There's no expiration date for that. So if PT doesn't work for 4 to 6 weeks, then go. And I usually tell them, I don't need 4 to 6 weeks. I need 2 to 4 sessions. That could be 2 weeks. That could be 4 weeks. That could be 3 weeks. We should start seeing some change.
Something.
Like, really? And I'm like, yeah, because based on everything we talked about, what I'm about to do is either going to piss it off or make it better. Both are good information for me to figure out where we need to go in terms of your treatment plan. Like, oh, okay. Well, yeah, if we piss it off, okay, we know we're in the right space. We just did the wrong thing. Okay, let's go back the other direction.
Yeah.
Oh, okay. Okay. I'm like, so you don't think I need the MRI? I'm like, are you going to do surgery tomorrow or the next day or the next month? And is that the path you're going? Well, no, I don't want to. Perfect. Save it. Hold on to that paper, stick it on the fridge. You can deal with it later. Let's try rehab first. And guess what? Rehab's only going to cost you a couple $100 for the next couple of weeks, and then you'll have a better idea. That MRI is going to cost you at least a couple $1,000. Insurance may cover some of it, may not cover it. How much is your deductible? How much? Oh, shit. I didn't think about that.
Yeah.
Yeah. Okay. Look at your plan real quick. Like,
Yeah.
we're a cash pay
Figure it
business, so
out.
we don't dive into it, but we can still tell them like, hey, be warned if you haven't. Oh yeah, I haven't done any medical. Okay, so you're probably going to pay $300 out of pocket for the MRI.
Yeah.
Oh, by the way, before the MRI, you have to get an X-ray, so it's going to be another $75, $80. Oh, but you need the physician to write the script, so that's another $50 to $80, depending on who writes it.
Yep.
Oh, now you need an ortho specialist to look at it. That's another $80 off a visit.
Yep.
You've just spent $500. Hey, guess what? That's a month of PT with us. Why don't we start there?
Exactly.
And it kind of reframes their mindset of, oh, okay. Like, well, you really don't need the MRI? Like, no. It's just a snapshot of what's going on. It's like, if MRIs and X-rays told you everything there is, radiologists would rule the world and would never work again.
Yeah.
Because it would tell you everything
It
you
would
needed
just
to
tell
know.
you everything.
Yeah. Oh, look at that there. Okay, go fix it.
Yeah.
Oh, look at that there. Go fix it. They'd be on top of the food chain.
Yeah. Yeah.
You know?
Well, no, there's some folks out there. I'm like, well, when do you have pain? Oh, when I do this, this, and this. I was like, do you have pain when you're sitting still, at rest, laying down? No. Does it happen right away? No, I have to be doing it for like a certain amount of time. And I go, well, you realize the MRI, you're just going to sit there in the machine and you're not loading your tissues. You're not doing something over and over. Like, sure, could we maybe come to a conclusion of like, oh, this is going on in there. So after you do X, Y, and Z 30 times, it starts to hurt. Maybe we could.
Right.
Or maybe we got to look at how you're moving.
Yep.
And that'll probably give us more of an answer.
Yeah.
How you're moving, if there's muscle imbalances there. Are you deconditioned? You know, are you dealing with other stressors that are contributing to this? And getting an image on that is just one, now we're chasing pain.
Yeah. Yeah.
And I'm tried not to chase pain as best I can. I've been there before.
I don't like running, and I don't like running after pain either.
I've been there, you know, where you're just, crap, what is it this?
Yes.
Is it that? Is it this? Is it this? And then you're just chasing it.
It's what we're trained to do coming out of school.
And you're just like, this isn't doing anything.
It was like the last pizza sitting there. I had to take it.
Man, I was looking at it. But yeah, I don't like being in that situation where you're just chasing someone's pain with them, because one, you start to create this environment around the pain that is very uncomfortable for the patient.
The focus becomes the pain.
And the focus is there. And that just, their outcomes are gonna be worse in that situation.
Yeah, the research shows if you ask people about pain, they're gonna have more pain. And what is the first thing people ask on intake forms and daily notes? How's your pain today?
Yeah, where's your pain?
They walked in with no pain, but now that you have them thinking about it, oh yeah, my knee is a little aching today. Now that you think about it, I have people that will literally search. They'll come in. You know what? I'm not feeling. Oh, there it is. Yeah, found it. It's a 4 out of 10 today. You walked in all spry and had a smile on your face.
Yeah.
How is it a 4 or 5 out of 10 right now?
Yeah. What?
You just had to. Don't go looking for it. I tell them, don't go looking for the pain.
Yeah. Don't go chasing it around.
If that answer is anything but a number right off the bat, the pain is fine. I usually ask, how's your weekend? How was your day? How's it going? You know. How's, events, current events, what do you think about this? What do you think about that? Never do I ask the first thing about pain, really. Because it's only one metric to test. How's your functional movement? How did you do about, your one thing? You wanted to pick up your grandkid. How did they go the last couple of days? Oh, it's better. Cool. They come back, oh yeah, the pain's still 3 out of 10. Oh, but guess what? You picked up your grandkid that you couldn't do last week.
Yeah.
That's a win. Give yourself a gold star.
Yeah.
Like, oh yeah. Like, forget about the 3 out of 10 then. You just did what you couldn't do before.
Exactly.
That 3 out of 10 is okay. Yeah.
The function. It's the function.
And they're like, I can live with a 3 out of 10. You're right. Holy crap.
Yeah.
Like, you got to start reframing it for them. You keep asking about pain. You're right. It's just, it's here today. It's here today. It's here today. It's here today.
And I think that's what we end up doing with this imaging sometimes, is that we start to create that negative space where it's like, oh, you got the pain there. Okay, we got to get you these injections. Okay, go do 4 weeks of PT. It's probably not going to work. You're still going to have pain. Then we'll get you the MRI. This whole scenario is set up that really puts, I think, us in a really tough spot as clinicians, and it puts the patients in tough spots too. And so, I really started to become very, like, just, I don't want to say anti-imaging, because there's times where I'm like, yeah, we probably need to get you in there, but just after so many times of seeing people's image, looking at their symptoms, it not matching or adding up, which for us as clinicians, and especially when you probably a new grad or you're just in your first few years, it is almost like you start having this like game in your head of like, okay, well, it says this, this, and this. Patient's not aware of all of this.
Right.
They just know, well, it says that. And then you're looking at their symptoms and asking them stuff. You're having them do stuff and you're going, it doesn't even add up. It doesn't even add up. Like this is, and you believe that it's this now.
Right.
And I'm sitting here going, there's no way
put on blinders now.
that it's that. It's not, it doesn't make sense that it's this.
Yep.
Your symptoms present like this could have been there for 20 years ago and just be asymptomatic, you know? Maybe you re-aggravated something from a long time ago and like, but your symptoms don't even match this. There's been, out of all the people that I've worked with, I mean, I can't even say 50% of the time. It's probably lower than that, where I look at the image, I look at them and their symptoms and I go, there it is. It's exactly that.
Yep.
And then we're going to do these two things and you're going to come back maybe one more time and you're going to be all good.
Yep.
It's such a small.
It is.
Small amount.
And I still remember one client that kind of got me to switch out of that mindset. She came in for like shoulder and neck pain. And they were absolutely certain it was her shoulder and that was causing the problem. And this was before I had done any of the McKenzie training and things like that. So didn't really have a good pathway to assess and evaluate spine and treat spine patients. So the doc is convinced you have a labrum tear. It was a fall, kind of shoulder neck fall type of thing. You've got a labral tear. And I'm like, are you having any of these symptoms? Range of motion was fine. It was just painful. Everything was painful. I'm like, this is not making sense. But she had already signed up for the surgery. Doc was pushing it. Had the surgery, recovered from the surgery. Still had the exact same pain. She's like, I fixed supposedly what was wrong. The MRI showed it was a labral tear. Doc said it was a labral tear. You're the only one that kind of questioned it. And by that point, I had already scheduled it and was already going through it. It was approved by insurance. I didn't want to deal with that. And now I still have the same outside shoulder pain. And I was like, okay. Called my mentor from Reno and I was like, hey, here's the scenario. He's like, do these two things for cervical spine. 3 treatment sessions later, pain's gone. Never needed the surgery. And I'm like, I had to apologize. Like, I'm sorry. Like, you got this surgery and I had that inkling that you shouldn't, but I just didn't know enough to get you. She's like, it's okay. You do now. You've helped me take away the pain. But it was a cervical problem.
Yeah.
All the imaging, everything was showing shoulder.
Yeah.
I put on the blindfolds and said shoulder, treat the shoulder, didn't look at anything else, didn't have all the tools to get everywhere else. So after that point, I switched. Like, okay, MRIs, X-rays, they're just a snapshot of what's happening.
Yeah.
It doesn't mean anything.
Yeah.
Look at the history, look at the symptoms, look at the mechanism of injury, talk to the client about function, same thing. I had one of my former clients actually call me. He's up in Reno now. Treated him for foot and ankle, something like a traumatic injury, but I was getting some shoulder pain. And he's concerned like, hey, I'm getting some numbness and tingling. I'm losing grip strength here and there. Doc thinks it's a shoulder issue. The MRI shows it's a shoulder issue. He was diagnosed with adhesive capsulitis. I'm like, didn't you just tell me you had full range of motion and it's just painful? He's like, yeah, I have full range of motion in all directions. It's a little bit stiffer than the other side, but it's not anything crazy. I'm like, adhesive capsulitis is frozen shoulder, which has a very specific pattern of movement loss.
Yeah.
So you're not demonstrating this. It's not this. He's like, you're sure? I'm like, yes. Go see my mentor. He happens to be in Reno. Go see him. I'm fairly certain it's coming from your neck. There's probably a disc issue or something in your neck or muscular that's causing this. It's not what they say it is. He's like, you sure? I'm like, have I steered you wrong before? No. That's why you called me. Go do this.
Yeah.
He's like, perfect. I got the MRI scheduled already, so I'm doing it. I'm like, perfect, but go here. He's like, perfect. I'm calling him as soon as I'm done with the doc. So he's like, texted me. I'm scheduled with him next week.
There you go. Yeah.
Yes. But it's stuff like that gets you to start kind of opening up and looking at, okay, this is just a piece of the puzzle. This is not the end all be all. This is not something to chase down. And again, we bring that term up, regional interdependence, right? You get an MRI of the knee. If the pain is coming from the hip, the adductor, muscle imbalance, movement issue, you're never going to see that on that one. Okay, so now what are we going to do? We're going to do another MRI of the hip, another MRI of the...
Yeah, you just keep doing a bunch of MRIs.
Right, nerve conduction study.
Start chasing stuff.
Yeah. Oh, let's do an MRI with contrast now. Let's do a nerve conduction. Let's do a EMG. Let's do...
Oh, man.
Holy crap, what are we talking about?
Yeah.
He had knee pain.
Yeah.
He had medial knee pain.
And
now we've done 45 invasive tests for this person. Oh, it's totally a meniscus tear. he's just been walking more than usual. And he
Yeah.
has knee pain because his shoes are 10 years old and he hasn't swapped them out.
Yeah.
Change the shoes, this guy's pain's gone.
But then it's that whole system that can create, and I talk to folks about this all the time. I'm like, once we've been dealing with this discomfort for over 6 months, over a year,
Yeah.
we have to start treating it a little differently, because all that like workup that you talked about obviously takes time. There's so much stress involved now. You're still trying to chase what's going on. Then we set up that person to possibly start having chronic pain type symptoms.
Yeah.
And so I try to have that conversation with most folks of just like, hey, like we're trying to make sure that you know, things get right. We improve your function as much as we can. But if things start kind of lingering a little bit longer, then we have to have a couple of different conversations about like managing your stress, making sure you're getting good rest, you're hydrating, you're like, you know, finding other outlets to kind of help with managing your stress, you know, like your diet, all sorts of things that can be like involved in having these types
100%.
of like prolonged pain symptoms. And it's just, you know, like you mentioned, you're working with people who are getting shoulder surgeries, but it's a neck issue. I've had several people get neck fusions and it was a shoulder issue. And I'm just going, please don't get a fusion.
Right.
Please don't get a fusion. Please don't get a fusion. And they're like, doc says I need a fusion.
Right.
I'm like, we just started like a week and a half ago.
Right.
You know?
I will go on a
And
soapbox
it's just-
on that because
I
people don't understand spinal fusion was never intended to treat pain. A lot of people don't know this.
Yeah.
The surgery itself, the indication is nerve damage or nerve impingement, radiculopathies, things that are causing neurogenic problems, nerve-related problems. It's not for pain.
Not pain.
And when I tell people that, they're like, I was about to have a surgery that's not going to actually treat what I have. And I'm like, yes. They're like, no shit. And guess what? As soon as you do it now, the level above is now at risk, the level below. And now you took that Jenga block out.
Yep.
Everything else is now
everything
tipsy-turvy.
else,
Unless you are pristine in your exercise routine and stay strong forevermore, which if you're in this spot, you're unlikely to have that kind of lifestyle as it is.
Yeah.
It's going to happen again. It's going to keep happening. You're going to have, I've had patients like, oh, I've had 15 surgeries on my spine.
Yeah.
Oh, you don't have a spine anymore.
There's
If you've had that many surgeries, you don't have a spine
there's
anymore.
nothing there.
So yeah, that when people talk about fusions, anterior, posterior, both, like please do not do it for the love of God. Please do not have a spinal fusion.
Yeah.
Period. Unless it is specifically for, hey, I have muscle weakness, I can't grip anymore, there's nerve stuff going on. Okay, now that's indicated and that's what it's for.
Yeah.
It's to decompress that nerve and give it space so it can do what it needs to do. Otherwise, it's not intended for pain.
That's not why we get that surgery.
Yep.
That's not why we get it. And I've, you know, the amount of people that I've had to talk with, unfortunately, after they've gotten that about the segment above and below and how the anatomy changes, and them not know anything about that.
No one's ever told them before.
Because they've not been told. They've had an imaging done. They looked at it. Someone said, you got to get a surgery now.
Yep.
Didn't tell them, okay, well, once you get this surgery, there's a high chance that we have to redo it again on the level above or below. Is this something that you want to continue on with?
Right.
Because you don't necessarily need it. You're not showing all those symptoms like you mentioned before. You're not having these weird neurological symptoms. You're not having the weird muscle reflexes or weird like ataxic gait and stuff like that, and bilateral symptoms. You know, you're not getting all of that stuff. So it kind of blows my mind sometimes what will happen after we see an image and not really treat the patient how they're walking in. And you know, there's times where I've seen imaging that says unremarkable, and this person can barely move. Because they're in so much pain.
And they're frustrated when they come in, like, the hell does this mean unremarkable? I can't move, I can't walk.
They're in so much pain.
This is a bunch of bullshit. This doc doesn't know what he's talking about. Like, I need to go see someone else, you know?
And then I've seen where I'm just like, man, that I'm not gonna say that looks terrible,
Right.
but that looks terrible. But you do every single exercise
Right,
I put
no
in front
problem.
of you with no problem at all.
Yep.
And you're like you function at a high level, and so why would we do this? Treat this? Why would we try to operate on this?
Yep.
For what? You know, so it's just, it kind of goes to show you that the imaging can lead you astray. Like, I'm sure we all have some stuff that will show up on imaging.
Oh, yeah.
You know?
Yep, we were just talking about it before, right?
We're going to have some stuff.
You have the ACL tear, or maybe my patella tendon's still tight.
Yeah.
I'm pretty sure I'm ACL deficient. I got a nice sulcus sign and a labral clunk when I tested. Yeah, we're collecting Pokemon. We're collecting injuries.
Yeah, we're doing it. We do it for you guys. We do it for y'all.
But going back to like the imaging and treating the patient, not that, the same thing goes for the script. I see people all the time. Oh, it's PFPS. Okay, here's your 5 exercises. Go. Mm-hmm. It's a garbage term. Adhesive capsulitis. Another one. Oh, pain in the shoulder, painful arc, whatever. Okay, yeah. Adhesive capsulitis. 6 months, you'll be fine. No, this person has a rotator cuff tear.
Yeah.
But they only treated the diagnosis. They only looked at what the physician said. And I always joke with clients. I'm like, what did it say? I'm not going to even look at it. Hold it up. Don't show me. It says 3 times a week for 4 weeks. Or 2 times a week for 6 weeks.
Mm-hmm.
Like, how'd you know? It's because 90% of insurances only cover 12 visits.
Yep.
So they're going to go 3 times a week for 4 weeks and then kick you out the door.
Mm-hmm.
Or 2 times 6 and kick you out the door, depending on their patient volume.
Mm-hmm.
They're like, what? You didn't even look at this paper. I'm like, I didn't. I just know this is the process.
Yeah.
And I'm like, I bet you doc gave you painkillers and muscle relaxers, told you not to do anything for 2 weeks, and then come see PT for 4. You're in my head. I'm like, this is the process. This is what they do. Yeah. And then they'll say X-ray, then they'll say MRI. Depending on your insurance, if your insurance is really good, they'll do the X-ray in office on your first visit. If your insurance is crappy, they'll wait for later.
Mm-hmm. Yeah.
Because you need the authorization and the process to do it. They're like, that's exactly what's happening. He's got me scheduled for an X-ray next week and the MRI the month after that. And he talked about cortisone injections. I'm like, And they'll do 3 and it'll be 3 months apart. It's like, how did you know?
Yeah.
And then they'll schedule the MRI. I'm like, yes.
This
and
is,
then your surgery is scheduled for 6 months from now. What?
Yep. That's the rundown. That's how they do it.
So I'm like, you can put that aside. I'll look at it, at some point during the session. We can talk about what it says on there and why it says it. But I want to talk to you. I want to know what's happening with you as a person.
Yeah.
Like, well, I have a knee and this, but I'm only here for my knee. I'm like, not this clinic. We'll treat you as a person. We'll look at your whole body. If you got neck pain, back pain, and knee pain, tell me about everything. Start with one and we'll go through the whole chain.
Yeah.
And I'll tell them, like, start at the bottom or start at the top. I don't care which one. You decide what's worse.
Yeah.
Okay, it's this one. Okay, let's start there.
Let's start there.
Like, wait, you can do that? I'm like, yeah, we're not a normal clinic where we have to authorize each independent body part as its own case. I still remember having a patient that had 3 or 4 things going on from a car accident, but they only approved things as pieces, as segments. So, we authorized his shoulder. Okay, but he can't walk. He's in a wheelchair, but I can only treat his shoulder right now. This poor man can't walk. I can fix his knee in 2 or 3 sessions, but we got to wait for the authorization.
Yeah.
I had 4 cases at one time open. I'm seeing the same client, but I have to document under 4 different charts.
4 different cases.
Yep.
You can't see him on the same day.
No.
So that means they got to come every day.
Yep. Basically.
Yeah. Literally
or delay their
every
progress
day.
where Monday's the shoulder, Wednesday's going to be your knee, Friday's going to be your hip. Oh, then the following Monday will be your ankle. And then we'll cycle through that. Why is this person not getting better? Because
I don't know. Because I only see him once every week and a half.
Yeah, exactly. Exactly. The dosage is off. Like, we're not actually doing anything for this person.
Yeah.
When they come to us and they're like, you can do, like, today we're working on your knee. If you, sprain your ankle tomorrow and come back in on Wednesday, we'll look at the ankle. It's no problem. Like, oh my God, I don't have to go to like another. No, come in. No. Come hang out with us. I mean, don't get hurt. I tell people all the time, like, don't get hurt. If we fix you and you're gone, good. Bring us baked goods. Come say hi. You don't have to get hurt.
Yeah, you don't get hurt each time. You can just stop by if you want to.
If you get hurt and have multiple things going on, we'll address them. So.
And I feel like that's how it should be. And unfortunately, a lot of clinics, they're unable to do that because of how insurance is. It's
an easy justification. I think it's a very easy out. I don't have to think as a clinician. I've got 45 people scheduled on my caseload today. cool. I'm looking at the document. Okay, it says patellar tendonitis. MRI shows inflammation of the patellar tendon. Okay, cool. I know what my treatment is.
Yeah.
I don't have to think.
You don't
I don't have
think
to
at
process. I don't have to decide anything.
Yeah.
I've chipped that all off to the doc and the imaging, and I'm going.
Yeah.
Whether or not it's right, I'm going with it because I've got 3 other people that just walked in the door too.
Yeah.
You know, so it's a system-wide problem, and I think it's going to take a lot to change it. I know there's clinicians out there because you worked for a clinic like that, and you were working your way to bust out of that kind of scene. So
yeah.
And for better or worse, social media is also promoting a lot of this stuff and having these clinicians look at some of this a little bit earlier in their careers. It's not taking as long to have the realization that we've had. They're doing it in the first year or two rather than 4, 5, 6 years in.
Exactly.
So,
Exactly.
yeah.
Which I think is good because now I love being able to do an evaluation on someone and okay, we got 3 different things we're working on.
Yeah.
We got 3 different things we're working on. That's what it's going to be.
Yeah.
Or if I get someone from home health and the script says low back and they're telling me, well, no, it's actually my knee that's been bothering me. I'll still evaluate low back and then I'll say, no, we're going to treat the knee.
Yeah.
We're not doing low back.
Yep.
Or we're treating neck, not shoulder, you know, like, and having that like flexibility versus being like, we got to open up 3 different cases. They're going to be here every day.
Yep.
They're going to get annoyed that they're there every day.
Yeah.
Because I have to be here every day, but I get paid to be here every day.
Yeah, we know you have a whole nother life.
Don't. You know, so it just, I think that moving in that direction, hopefully in the future of being able to treat the whole patient that walks through the door, not the neck pain patient, the shoulder patient, the MRI that had a disc patient.
Yep. Oh, that's the 4mm guy.
Yeah.
Oh, that's the bucket handle tear over there.
I mean, I just wanted to get to the point where it's like we're treating AJ or we're treating Anthony or we're treating Bob. Like, just, you know, that's how I think it should be. So I'm glad that here we're able to do that.
Yes.
Yeah.
Absolutely. All right. I think we both got a little bit off of our soapboxes there.
I think we did.
Definitely tons to unpack with this topic in terms of imaging and treatment protocols and kind of the decision-making process, both on the medical side and on the PT kind of rehab conservative management side. But I think we're good on this topic for now. Mm-hmm. Maybe we'll do a follow-up and continue on. But I think that's it for today. So thanks again for sticking around and chatting with us and listening to us get off on our soapboxes a little bit today. As usual, we don't know how long these will be. We don't know when the next one will drop. We don't even know what the topic will be, but we know we'll be back. So come back and check us out again. Yes.
Nice. Nice.
We got
wasn't
the
us.
It wasn't us.
It wasn't us.
Safe.
It wasn't us.
That was the best.
2, 3. For the record, I didn't hit record on the cameras before doing the slate, just so we have record on camera on 3 different
Here, blooper reel worthy right there.
Yeah.
All right.